A man was in a waterless plain when he heard a voice from a cloud. Water so-and-so's garden. The cloud moved on and poured its water on a rocky land, which flowed into a channel. The man followed the water and came upon a man standing in his garden and diverting the water into it with his spade. The man asked the gardener, "What is your name?" He told him his name, which was the same name as he had heard from the cloud, but asked, "Why do you ask my name?" The man said, "I heard a voice from a cloud, whose water is here, to water so-and-so's garden, taking your name." He then asked him, "What is special that you do to deserve such heavenly blessing?" The gardener said, "Since you have asked it, I divide whatever produce this garden gives me in 3 parts. I give 1 part in charity, spend 1 part for myself and my family, and reinvest 1 part in this garden."
Narrated by Abu Hurairah in the collections of Muslim.
Broadcasting 24 hours a day, 365 days a year. This is Salam Radio.
Assalamu alaikum. This is Dr. Shabina Asad Qayyum for the Body, Health and Mind Show on Salam Radio 106.2 FM. I always await that jingle that goes off at 7 p.m. on a Wednesday because it is so good to be back with you all in my what I call me time of an hour of this show, where I try to bring the latest developments in health, particular to the community and the Muslim community, to your very own community Muslim radio station, Salam Radio. Wonderful to be back this week, and I'm going to introduce my guest shortly, but I just thought I'd remind you that the 10th of October marks World Mental Health Day, which is quite significant for all of us. And I especially wanted to talk about this topic here in the studio. But if you've tuned in with me, you will know that we are broadcasting live on Facebook. We're also broadcasting live on YouTube Live, Twitter Live, Instagram Live. And if you'd like to participate in the show, make sure you text and WhatsApp us on 07745 278 978. Or you can ring us on our studio telephone number and have a conversation with us, or ask us any questions on 01733 602 133. I'm Dr. Shabina Asad Qayyum. I'm a local GP who practices here within Peterborough. And I love what I do. I love treating patients. I love seeing them. And I love this show as well, that I come to every single week to deliver the best of the news in health to you. So without further delay, let me introduce you to my wonderful guest, who is called Dr. Mansur Butt, who is a consultant psychiatrist. He's done his MSc in psychiatry and MRCP Psych from Manchester University. Now, I'm going to tell you a bit about the accolades of this doctor, because he's worked in medicine, he's worked in anaesthesia, he's worked in gastroenterology, public health, the media, and would you know that he's also a former DJ and host of FM 100, which is a station in Pakistan. He's a published poet and has written columns for Al Akhbar newspaper, and he has been affiliated with different psychiatric subspecialities for the last 15 years. He's a current consultant psychiatrist in general adult psychiatry at the Mersey Care NHS Foundation Trust, and has completed his CCT, which is the completion of your specialist training in general adult psychiatry with endorsement in liaison psychiatry. And he's also researched in cultural aspects of psychiatry. So let's bring him onto the show. Dr. Butt, assalamu alaikum.
Walaikum assalam, Shabina. How are you doing?
Fine, thank you very much. Now, I had just been going through all of your accolades, mashallah, which is wonderful. And I just wanted to, I was very interested in the whole DJ aspect. How long ago were you actually involved in radio?
Sounds like ages.
Okay.
That was somewhere between 2000 and 2004, 5, something like that. So, yeah. But in them days, we didn't used to have live streams, so it was, I think, a lot easier.
Yeah.
But anyways, yeah. So that was one enjoyable part of that.
Oh, that's wonderful. As I enjoy it too, just over here, you know. So it's wonderful that you have come to the show, given us your very valuable time about a very, very important topic, Dr. Mansur.
You're more than welcome.
So, what led you, after all of those specialities, medicine, medicine, anesthesia, very different specialities, and then all of a sudden psychiatry. How did that actually come about?
Yeah, I think I mean, there's no other way of describing it. Like, I just sort of rotated through different specialities. And when I was in Pakistan, unfortunately, in them times, psychiatry wasn't that much developed, especially in the context of third world country, developing country. And but when I was preparing for my PLAB examination, the UK licensing exam, so I started reading psychiatry, and then the interesting bit is, if we look around, all of us have got someone, either a distant relative or someone who has got some psychiatric problem. My aunt, one of my aunts, bless her, she's no more, but she had OCD, the hand washing problem.
Yeah.
And once I was on a medical ward, and some of my PG colleagues, they looked pretty scared, and I asked them like what happened, and they go like, look, this girl, we were treating her for this and that infection, and now she's got psychosis, and we don't know how to manage her. So initially what looked like pretty scary, but then gradually, as I read along after PLAB, then I developed this interest, and knowing human mind, talking to fellow human beings, I always like that. So it's more like treating the person as a whole rather than just, like simply via mathematical equations. I mean, that's how it sounded like that to me. But but I enjoyed talking to my patients and colleagues. So yeah.
Yeah, and you've never looked back since, because you've developed and you've become a specialist in the area. And I think when we look at psychiatric illnesses in ethnic minorities, it's important sometimes, and we have a great shortage, I think, of consultants in our area at least, who have the ethnic minority background, in which they're able to understand the cultural aspects behind mental health and certain conditions. And it's a really come at a really apt time, this show has, because of World Mental Health Day on the 10th of October. And it's great to have somebody like yourself to talk about this. So for the purposes of, because it's a very straightforward in terms of information distributing show, in which we like to invite our specialists to talk a little bit about their subject matter and things that should be easily understandable to our listeners. And would you like to tell our listeners a little bit about the most common mental health issues that are prevalent?
I think depression is on the rise across the globe. And we have got in ethnic minorities and their perspective, some of what we call severe enduring mental illnesses. The prevalence and the incidence is roughly the same across the globe. For instance, schizophrenia will be less than 1% in Japan, in Africa, in India, in UK. But I think most commonly what we're coming across is now depression being on the rise. And in the context of ethnic minorities, I think the GPs, sometimes we kind of advise them as well that, look, an Asian man is not going to come to the GP's clinic saying, "Doc, look, I'm depressed, please give me some antidepressants." It's always going to be some kind of aches and pains, some headache, or some other psychosomatic kind of problem. But if you look closely, then obviously there'll be other stresses in their life. One thing, being from the like, now I've seen the best of the two cultures, and I can tell, like, if you asked me more than a decade ago, or maybe 15 years ago, to even go to my GP and describe in simple terms if I were depressed, to be honest, I would have struggled. it takes a long time because I'm the first generation immigrant. So the second and the third generation, that yes, they can communicate and they know the slangs and know the phrases and how to express themselves. But with the first generation immigrants, it's extremely difficult for them to even precisely describe what they're going through. Um, Knowing different languages, Punjabi, Urdu, Patwari, Padi, Meepri, those kind of languages, and I can understand bits and bobs of Pashto as well. So sometimes when we book interpreters, and when I know the language, it's I can feel sometimes it's not being conveyed properly if you know the language, you know. So sometimes there's always data which has gone missing in the interpretation. So that's where it's a different sort of the illnesses are there, the disorders are there, but the presentation might be slightly different than the local population.
And I've often found, Dr. Butt, that within primary care, because often people will present, if they are brave enough to their GPs, and I often see, and that is part of what I try to explore, which we call the psychosomatic symptoms, in which sort of psychological illness manifests as physical problems. So, for example, in my practice, which it provides services to a rich ethnic diverse community, I often see an elderly frail woman with English as a second language, as you say, who will complain of bony aches and pains and never really look quite happy. But upon exploration, I find that the challenges that I have is that nobody really wants to openly talk about mental illness. So nobody really will open up and accept the fact that they are depressed. So if you say, for example, I would say to a patient, is there any stress? Because that is the easiest way of them being able to understand that there is an underlying mental illness and to answer the question more amicably. But I've often seen that there is always a refusal. No. And it's behind that no that you often see through the body language and the eyes that there is a lot more to what I am being told than a simple no.
Yeah, it's amazing, and I think partly it's because of the stigma attached to the mental illness, and what even makes it worse is the lack of knowledge or basic information around mental health. So people in India and Pakistan and Bangladesh, etc., if God forbid someone has got a gunshot injury or a roadside accident, they would rush them to the hospital to get the bullet out or get them fixed and all the kind of reductions in the joints and this and that. However, when it comes to the mental health, so everyone comes in handy, the whole family, and it's an extremely sensitive issue, but there is an overwhelming sort of dependency on other, what in Urdu is called totka, means the local sort of remedies or the cultural remedies, like hakims, and some people would say, okay, you go and recite Quran or do your namaz, offer your salah, and you'll be fine. So my question usually is, spirituality, there's no doubt, evidence-based science suggests that spirituality is a protective factor for mental health, regardless if it's Islam or Christianity or if it's Judaism or Hinduism. So spirituality is protective. However, my question is usually if someone comes in with a gunshot wound or road traffic accident or a myocardial infarction, would you wait for like a cleric to come and first give them some recitation, or you would rush them to the hospital? So similarly, what happens is, like many other problems, many other medical ailments, even with psychiatry, what happens is people go to different places, to different people, and different kind of spiritual healers, and they see Totka healers and Hakims. By the time they've come to the hospital, the person has already gone into severe sort of psychotic depression, and then it becomes extremely difficult to treat that, and we need to admit them. So apart from the stigma, the lack of knowledge, and other factors, it becomes difficult to tease out the symptoms at the right time and treat them.
And for the purpose of our listeners, because we are creating awareness, and part of that awareness is giving the right type of advice, when would you advise patients to go to their GP without fear of speaking about it? Because it's very difficult for people within these communities to open up. How would you go about advising these people to do so?
There's a slight difference in ladies would usually go and in their own way try and discuss it with their GPs, but men, then that's kind of global, as they won't admit that they're weak, which they're not. An illness is an illness. It has got nothing to do with weakness, any kind of that kind of weakness of character or anything, or the male sort of weakness. No, so it's I think now, apart from depression and anxiety, even stress, ongoing stress, long-term stress, and it is now included in the diagnostics, and some people treat it like any other severe enduring mental illness, because what happens is long-term stress causes burnout. So rather than waiting for the full-blown symptoms of clinical depression, when a person becomes suicidal, or sometimes psychotic, not making much sense, stops eating and drinking, etc., stops looking after them. So if someone is feeling that they have got a burnout now with ongoing stress, so they should go and talk to their GPs, and there's no harm in giving them a trial of SSRI, that is the newer generation of antidepressant medication, as partly to treat mild to moderate depression and partly to prevent slipping into more severe form of depression.
Yeah, well, thank you for that. Now, we've got quite a lot of interest that has been generated in the show. I can see there are quite a few views online. I'd like to thank Sister Azima Akhtar for, first of all, sharing the show and saying, well done, my lovely. Thank you very much, sister. And for all of you that have just joined, you are here on the Body, Health and Mind show with myself, Dr. Shabina Asad Qayyum, and I am with consultant psychiatrist Dr. Mansur Butt of the Mersey Foundation, NHS Foundation Trust, and we are talking about general psychiatric problems because he's a consultant in general adult psychiatry. So we really hope you'll be able to benefit from this show. Please do watch us on Facebook Live. If you'd like to ask us any questions, text and WhatsApp us on 07745278978, or you can ring us on the studio telephone number 01733602133. And just before this announcement, Dr. Butt was talking about how one should be recognizing the signs and symptoms and going to their GP for help. And he's described the symptoms of clinical depression. Now, there are obviously a lot more serious illnesses, aren't there, that need a relatively more urgent attention, like psychosis, for example. Would you like to tell our listeners a little bit about that and what those symptoms are and what psychosis is? Because some family members think that people, especially within ethnic minorities, are possessed as it is if they present to say that they're hearing voices or seeing things that they shouldn't see. So would you like to tell our listeners a little bit about what psychosis is and how urgently those patients need to then be seen?
Okay. Yeah, that's an interesting one. Now, psychosis usually, psychosis is an umbrella term. It's more like a syndrome. It's more like a set of symptoms. It's not a diagnosis per se, because there are many different things that can cause psychosis. Drugs and alcohol, head injury, hypoxia, any other neurological conditions, post-ictal psychosis, or in between the two epileptic fits, people can have psychosis, and so on. So there are so many different, a variety of causes that can give a person psychotic symptoms. However, talking about schizophrenia, and there is a hereditary, or in layman's terms, like the so in certain families, there's a tendency towards having this predicament. I know I've been treating someone in the past in Pakistan, where in one family, and because of I'm not for it or against it, but just to let you know, they talking about cousin marriages, and like it's like never marrying out of the family, and given the pool of the genes, so getting so much so concentrated, so they were like four siblings suffering from more or less similar sort of schizophrenic kind of illness.
Wow.
So it was really difficult because either the natural course of the illness is relapsing, remitting. So sometimes one person would be relapsing and then the other would be relapsing. So the things to look for, especially with schizophrenic illnesses, is it's usually an illness of teenagers, you can say, or late teenagers. In females, there can be a slight delay, could be in the 20s as well. There's no there's not like a fixed kind of time period. However, just generally, let's say it's teenagers and early 20s. Now, for general public, sometimes people use schizophrenia as a term, again as an umbrella term, but there are so many different types of schizophrenias. Some are more withdrawn kind of symptoms, carrying withdrawn kind of symptoms like depression. So let me give you an example, like the young boy who was doing okay academically and going out with friends, and suddenly one day after we call it a prodrome, like there's a phase of a couple of months to a few months where he will be perplexed, trying to figure out the reality around him, and then suddenly the truth dawns upon him, and so on. So basically meaning that the young lad who suddenly stops going out with friends, stops going to school, goes into the attic, and only comes down to eat his dinner or supper when everyone else is gone. So that's a kind of schizophrenia where the picture is of a withdrawn young lad who's withdrawn. Then there would be other kind of like paranoid schizophrenia, so they could be positive, although there's nothing positive about it, but positive symptoms is just a name given to the symptoms. We're talking about hallucinations, and we're talking about delusions. So that's one thing which you have to keep an eye on, these kind of things. I think it's, to be honest, if like parents and especially moms, they can tell when there is some changes in the teenager, or they can tell that a child is, say, talking about autism or something, they can tell the difference, that their child is different from rest of the neighborhood kids, siblings. So it's hard to go through the whole of the ICD-10 in limited time period. However, the message would be anything unusual, especially in the teenage. There's no harm in going and asking your GP to get referred. It's not gonna cost you anything, and if it turns out to be not the case, that it's not, at least you've ruled out that aspect of the mental illness.
I find it really interesting that you've informed us that this is a illness of teenage years. So something biochemically changes due to whatever. I mean, I remember seeing a patient who had been placed on, for example, a treatment for acne, and that I had no idea that a side effect of that was, and this was not initiated by myself, I'd like to say, but that initiated psychosis. And it was somebody who had an extremely promising future ahead of them, and 2 to 3 years of their life had actually just completely gone, because they then had to be transferred to the psychiatrist, who then placed them on treatment that didn't in effect work, and he was put on something else. So the impact that medication can also have in causing psychosis is also very important, isn't it?
It is this is jargon, the iatrogenic or hospital-induced, you can say medication-induced kind of psychosis. For instance, some people can be on steroids. The GPs prescribe them for other indications, and not everyone, but some people, they come back within a few days to a few weeks, and they get proper episode of psychosis or mania with steroids. So medication. There are also the medication that can mimic a psychotic illness.
Wow. And can I ask, when you talk about the effects of psychosis, does the same also apply to topical steroids, or are we talking oral steroids only?
Mostly oral steroids or injectables. Topical, in my clinical experience, I'm not sure if there are any case reports, but as far as I know, I've never seen anyone having psychosis after topical steroids.
Yeah, because obviously the oral content of steroids, and depending upon what condition you give it in as well, has a far more systemic effect than topical steroids, which are often used quite sparingly as well. Now, it's wonderful. We're running up to a break. We've got about a minute before we run into a break. And I think that we've covered quite a bit in terms of sort of psychosis, and I think it'd be good to, you've spoken a little bit about schizophrenia and depression as well. I'd like to talk a little bit after the break about anxiety, its implications, how to identify and what the treatment could be, and a little bit about the fact that there's a long waiting time as well for people accessing mental health services, which isn't something that we have much of a control over. But it certainly would be something to talk about. So, Dr. Butt, thank you very much for bearing with us and your patience as well. It would be wonderful, hopefully, to see you after the break. So don't disconnect. And we'll have a 4-minute break, hopefully, inshallah. And we will come back and we'll talk a little bit about those factors. So thank you very much for staying with us. So hopefully, listeners, we will join you after the break, where we will talk a little bit more.
Stay tuned to Salam Radio after this short ad break.
The masjid is a center of spirituality, education, and a social hub for the community. In the times of the Blessed Prophet, peace and blessings be upon him, the masjid lay at the heart of society and was not just a place of sanctuary and prayer, but also a thriving educational institution. Prophet Muhammad, peace be upon him, is reported to have said, "Whoever builds a masjid for Allah, be it large or small, Allah will build for him a house in paradise." Sunnah al-Tirmidhi. The role of the masjid has always been instrumental in the educational, social and moral uplifting of the Muslim community. Please donate by visiting childrenofadam.net or call us on 0300 321 0032.
Had a car accident or an accident at work? Accident specialists are experts in no-win, no-fee accident claims. Leave the hassle to us. Our multilingual settlement experts will manage the entire claims process on your behalf, with nothing to pay up front. We provide services such as credit hire, taxi vehicles, recovery, storage and much more. For full details on our range of services and a free consultation, on 01733 555 774 or visit our office at 249 Lincoln Road opposite the NatWest Bank. Accident Specialists. Start your successful claim today.
Feel like some great tasting chicken tonight? Great meal deals, wraps, burgers and sides. We've got it all at Chicken Palace. Call and collect at 302 Lincoln Road on 01733 702 447 or 8 Park Road on 01733 343750. Chicken Palace, open 11 a.m. till late.
दोस्ता की परेशान है
जरा कर है ना सारा सौदा मुक्या वा मुल्का विच पैसे भेजने
हूं नहीं मार फूड वाले की फोन खड़का ते फ्री लोकल डिलीवरी कार मंगवा
आला ता उथे कै स्पेशल आ
उना की लबाई हाइजीन च ग्रेड 5 चीजें चंगियां मियारी ते सस्तियां ते नाले ऑफर ही ऑफर
और क्या
ताजा गोश्त ताजी सब्जियां ते फ्रूट आटा चावल दालां मसाले ते जूस सारे बिल जमा करने गैस ते इलेक्ट्रिक ने टॉप अप भी करने पाकिस्तान पैसे बिल्कुल फ्री भेजने मतलब के एक चिड़ी ने दूध छड़ी ते हर शय लबनी
जने ने आप उतरा
Amar Food Store and Halal Meat 613B Lincoln Road Peterborough telephone 01733 687374
Gems and jewels, wise sayings interesting events and moral lessons from Islamic history. And who is the fool?
A man of great wealth and status built for himself a house, adjacent to which was a small and shabby house, not of much worth, which was owned by an old woman. Her rich neighbor needed her house in order to embark upon an expansion project that he had in mind. And so he offered her an exorbitant amount of money in order to purchase her house, but she refused to sell it. It was said to her that the judge would freeze her assets because of her foolish persistence in not taking a large amount of wealth, especially considering the fact that her house was worth very little in the first place. She said, "And why does the judge not freeze the assets of the one who wants to spend and waste such a large amount of money for a house of so little worth?" She refused to sell her house, and she was able
Broadcasting 24 hours a day, 365 days a year. This is Salam Radio.
Assalamu alaikum and welcome back to the Body, Health and Mind Show with Dr. Shabina Asad-Qayyum and my special guest, Dr. Mansur Butt, who is a consultant psychiatrist at the Mersey Foundation, at the Mersey NHS Foundation Trust. I always get those two mixed together, and it's wonderful to have you back, and thank you so much for sharing the videos. And you know what? This week I'm going to give a shout out to Sister Razima Akhtar, who is so supportive of so many sisters in the community, and the fact that you want to share the show and create awareness about mental health in an attempt to remove the stigma says so much about you. Thank you very much, my beautiful sister. Very grateful to you. On behalf of Salam Radio, on behalf of the Body, Health and Mind Show, Jazakallah khair. Now, Dr. Butt, thank you very much for bearing with us and giving us your valuable time. And actually, we've generated a lot of interest. A lot of questions have come through. Before we address those questions, first of all, I'd like to I'll go back. I have a question here from one of my wonderful colleagues, Dr. Azhar Chaudhry, who is a fabulous colleague of mine, local GP too, we work together in the capacity of the British Islamic Medical Association. And he is asking, my understanding is that iatrogenic psychosis is reversible.
Yes, it is. It is very much reversible. Like you apply logic to some of the medical problems, that if whatever is causing it, if you just withdraw it, then the problem should be sorted. However, sometimes, given the seriousness of the situation, or because of possible risk to the patient and people around them. So we use antipsychotic medication in certain dosages to address that issue, and it is very much reversible.
Okay. My question in relation to that, Dr. Butt, would be that how long can we expect reversibility of this psychosis? So how long would a patient have to expect improvement in symptoms, if anything?
It's practically not possible to give a precise timeline, because everyone's different. The networking in the brain is different, genes are different, neurons are different, and the pharmacokinetic. Try not to use the jargon. So the way the body deals with the medication and sort of absorbs it, and the way the medication then deals with the body, and so on. So it depends on all that. However, I have got good faith, and if you ask any of the psychiatrists in the UK, they'll have good faith in antipsychotics. Antipsychotics really do work. As quick as I've seen people having a difference within a couple of days.
Okay.
So young lad coming in, mom bringing him in, extremely scared, irritable, or not being able to figure out what's happening, what are these voices. You give them a tiny dose of a particular antipsychotic. They could be favorites for different psychiatrists, but there is the older term was typical and atypical, or you can simply say the older medication with more side effects, and the newer generation of antipsychotic medication. So you give the medication to the patient, And I've seen people coming back right the next day saying that they can tell the difference. At least, if it's not 100% cured, at least they can. They're less sort of scared. They're less confused, and they're less distressed by the symptoms.
Okay. Well, that seems to have satisfied my question. Now, let's talk a little bit about anxiety. Now, a while ago, it was observed during the summer holiday. I've seen a lot of young people making the transition from primary to secondary school, and this is within our communities, and likewise undergoing exams and waiting for exams. And I have seen an awful lot of anxiety, and far more proportionately than I would have anticipated when back in my day, for example. This could be due to peer pressure, this could be due to changes in environment, the curriculum, the fact that lifestyles have become a lot more sedentary, etc., etc. Could we talk a little bit about what anxiety is, why does it happen, and how to deal with it, please?
Sure. More commonly in the clinics, what we see is anxiety-related problems, and sometimes anxiety and depression go hand in hand. So if you're an anxious person, there's performance anxiety, or there's anxiety of going outside the house or to the new institution and so on. So that can affect your mood naturally and make you depressed, or vice versa. And if you're a depressed person, that can make you anxious as well. So at times it goes hand in hand. So now anxiety, I'm going to say something which usually doesn't come from the psychiatrist. Anyways, I can speak for myself, but anxiety is really important for us, for our survival, to begin with.
Oh, that's interesting. I find that an interesting sentence, actually.
So some of the anxieties are, we call them the collective human archetypes in human infants or toddlers, or other animals. For instance, the chimpanzees, they're young ones. If they see a snake, no one has told them, but they would start making noises and be boisterous. Similarly, human child at different stages of their growth, they have got different kind of anxieties and phobias and fears: fear of height, fear of strangers, fear of loud noises, and so on, which is important for the survival of the human race. Remember, once upon a time, we used to live in the caves, and when we went out of the cave and saw the beast, and it started chasing us, so the sympathetic nervous system kicks in. So one of the type of the nervous system which is related to adrenaline and etc. So more blood being pumped to muscles, simply preparing us. It's like an alarm going off and preparing us to the commonly used phrase, the flight or the fight sort of response. So either we fought the beast or the wild cats, or we ran away, and that was important for our survival. So if there were no anxiety, we would have not survived. Similarly, tiny bit of anxiety or stress on a daily basis is important and keeps us going.
Mm-hmm.
If I were not anxious about my specialty examinations and I never bothered preparing for them, I would have never made it. You know what I mean? So I needed to be a bit anxious and worrying about them and so that I could start preparing for them. However, what happens is, now this is the normal inbuilt anxiety. In various different forms of anxiety, we call them anxiety spectrum disorders. So anxiety spectrum disorders can be anywhere ranging from generalized anxiety to specific phobias, to panic, to OCD, to PTSD kind of symptoms, and so on. So anxiety spectrum disorders, when it grows out of hand, that much, kind of, it becomes distressing that the person who was supposed to prepare for the exam cannot even start preparing. Rather, he or she spends that amount of time in thinking about it and worrying about it and going into that many nitty-gritties and all the possible details that practically they can't even start preparing for the exam. So that's pathological kind of anxiety, which makes you dysfunctional, which disrupts your routine, which stops you from achieving your aims and objectives. So that needs treating. Similarly, when I spoke of the alarm going off, so in some cases, especially talking about panic, it becomes more like a false alarm. So there's no real monster out there, but perceived threat of the monster, we've all got our own demons and monsters and problems. So the perceived threat triggers off this false alarm every now and then, and the person who goes through this panic symptoms, for them it sounds like or feels like the end of the world. It's dreadful for them. So that again needs educating and addressing.
And how do we help such people? So normally, anxiety to an extent never really needs to go to a specialist, because I feel that GPs are quite well versed in taking care of that condition, depending upon the degree of anxiety that one is experiencing, because it can be linked in, as you say, with depression and other things, OCD, like you mentioned too. So in our field, within primary care, we often see somebody who's an anxious person, and often counselling, therapy, something known as cognitive behavioural therapy can be implemented as well. And often I do signpost them to an app called Calm, which has a lot of mindfulness, breathing exercises, meditation, techniques, self-help techniques as well. And I find that quite useful. But there are some people that will get panicked or anxious in certain situations and would express the need for medication, something such as a beta blocker. How effective are these medications in the short term at the state of the moment in helping people with their symptoms?
Yeah, I think medication in anxiety spectrum disorders can have a role. Especially if it's chronic or debilitating kind of anxiety. However, I would usually try and avoid something which is extremely sedative or which develops dependence. Means, in again, jargon-free language, people get hooked onto them, they become dependent onto them. They can be used in short term in the hospital setting. I would not encourage to use them in the community, because then further dependence is developed. And what happens is then we start brushing kind of some of the things under the carpet, but the root cause is not addressed. Evidence-based science suggests that for both depression and anxiety, and especially anxiety, the outcome is better when therapy and medication go hand in hand. The different kinds, you mentioned cognitive behavioral therapy, so using that model, and then there are various other models within that. So there's specific CBT for depression, for mood, for negative thought. There's specialist CBT for phobias. There's specialist CBT for generalized anxiety, and so on. So evidence-based science suggests that the outcome, if medication combined with therapy, talking therapy, it carries a better outcome. Plus, it's also better in preventing a relapse as compared to either of them on its own. So it's good if someone can have access to psychotherapy, either at the primary care or at the secondary care. Okay.
I have a question from our local GP, again, my wonderful colleague, Dr. Azur, who, by the way, inherently and intently listens to my show every week. And you know what, Dr. Azur, you have earned your shout out next week, so I will make sure that I give that to you. Now, Dr. Azur has asked, thank you for the answer, for the previous answer that you gave, and has asked, can you please ask about the management of insomnia without depression and anxiety symptoms? Because it's a very common presentation at present, and we have been told not to give benzodiazepines, or Z drugs as they are, for insomnia. How would you deal with or treat insomnia?
I think regardless of the diagnosis or whatever predicament they come in with into my clinic, I would say most of the people would complain about not having a calm, refreshing sleep. Uh, so if you look at the latest studies around insomnia, within insomnia, then there are like sub-classifications. Sometimes what happens is what's being described as insomnia is more of a sleep-wake cycle reversal. So for instance, from tonight, if I start pushing my sleep a couple of hours, like towards midnight, and then tomorrow another hour, and then day after tomorrow, so if I carry on doing that, within a few days or within a week's time, I'll be up and about the whole night, and then I'll have tiny bit of naps in the day, which are not going to be refreshing anyways. The biological clock is set for the nighttime sleep, and which is it gives us more calming and refreshing sort of feeling. The other thing is most of the studies would tell you that the subjective feeling of a person of how many hours or how much they're sleeping is usually I mean, no offense, but that's what most of the studies, like when you monitor people for 24 hours, and so usually people underreport their subjective feeling of how many hours they've been sleeping. The reason being, it depends on the quality of sleep. By no means I'm not suggesting that people just make it up. Basically, their subjective feeling that they still feel tired even after 12 hours. So there are people who are well trained in shift work, doctors, lawyers, others. In my younger days, I could sleep anywhere, on the floor, on the sofa, on the table, in the operation theatre, and so on. So people who are used to having shift work and stressful work, and they have trained their minds in a way that on a couple of hours kind of flight, they just go off to sleep, and when they wake up after those couple of hours or 3-4 hours, they're absolutely fresh. Like on the motorways, that it says like tiredness can kill, and so research suggests a 20 minutes nap can significantly reduce the chances of accident when you are exhausted. So, however, there's still another population of patients. So what they do is either they're not sleeping, or they're tossing, twisting in the bed, or they don't achieve that amount of deep sleep, which then gives them this feeling that they're not sleeping enough.
Right.
Medication, you're right about benzos. It's not a good idea because of tolerance and dependence. So tolerance is if you take one tablet and start the Z tablets and start taking them on a daily basis, then pretty soon they'll stop working for you, and then you will need more and more, and then people end up. So the real problem remains the same, and then people end up buying off the street, and so a new problem then starts with dependency and all those issues. So I usually do not recommend long-term use of benzodiazepines. Maybe in extreme desperate kind of situation, maybe a short course, and ask the patient to use it wisely and sparingly, like skip days in between, and in that way, so a week's worth of such pills should last someone a good few weeks if they use it wisely and sparingly. So that's the medical kind of management. However, the further kind of research suggests that if you want to have a good, calming, deep kind of sleep, for that, just imagine there's a sleep kind of cylinder, and you need to fill it up to the brim, and by the time you fill it up to the brim, then you just hit the bed and you go off to sleep. And the fuel for that kind of cylinder, just imaginary cylinder, is tough physical or mental exertion. So sometimes it's quite straightforward. It's hard to tell the patient, like, it depends on the lifestyle. It depends how structured your day is. It depends on your sleep hygiene. It depends what amount of caffeine or smoking or alcohol you're using. So things like sleep and weight, my kind of it's more like a philosophy rather than science, that you can't lose them in a day, and you can't get them back in a day. For instance, you can't gain like a couple of stones in a day, and you can't lose a couple of stones in a day. It's a lifestyle, so it's going to take time to manage it. Similarly, with sleep, you're not going to get back your sleep within a day just because you prescribed a few pills. It needs the lifestyle needs changing.
Yeah, I think that's right. Now, in answer to Dr. Azhar's question, and I really do take on board and thank you for your answer, I've seen locally here within Peterborough, and I don't know if Dr. Azhar has experienced this as well, but I've seen quite commonly the use of promethazine, which is in other words Phenergan, an antihistamine. And I find that quite useful because it's not addictive really. And I find it quite useful for short-term sleep solutions, and it can also be brought over the counter as well. What are your thoughts on that, on promethazine? Do you think that that's a good alternative to giving benzodiazepines?
I think if it's not indicated for insomnia, then it should be used for that would be, in a way, would be a misuse of what it's indicated for. However, as I said, in desperate situations, maybe a tiny dose, occasional, but then with them kind of medication, as we all know, sometimes it can backfire with paradoxical agitation and other issues and dryness of the mouth and so on. So if there's no physical dependency, at least there can be a psychological dependency on that chemical then. So again, I won't recommend using long-term Phenergan for just to address the sleep issues.
Yeah, okay. Phenergan also is available as Sominex. And the reason why it's called Sominex is because it says on the packet for short-term sleep solutions. So that sort of indication is there. And also Dr. Azhar is saying that we use that, and we also use amitriptyline 10 to 20 milligrams at night. And obviously amitriptyline was your olden day antidepressant, wasn't it?
Yeah. And I think, as I said, the short-term use, either benzos or Phenergan or any kind of sedatives, the short-term use in desperate situations is okay. But that should not be used to achieve long-term, in the long run, sort of achieving a good, calm kind of sleep. It should rather be used more to set up a cycle, to kickstart a cycle, when you're trying to get back to your sleep. But then you have to take other measures, like waking up at a certain time, all the sleep hygiene kind of things. So patient needs educating on that, and I think putting too many expectations on just a pill and hoping that it's going to carry on working for the rest of the life or for months and years to come, that's not going to be the case.
Okay, well that was quite a comprehensive answer, so thank you for that. Now the last question I've got, and I hope Dr. Azhar that's answered your question as well. Just before we end the show, I'll take on another question. And this gentleman is saying that I've had depression for a number of years. However, each time I've recovered and I have followed the advice of the doctor, I have weaned off the medication as advised, and I will always get my symptoms that come back. The last time I was on an antidepressant medication was for 2 years. I was weaned off by my doctor for the specified amount of time, and I have been again diagnosed with depression. Why is it that doctors cannot be honest and say to us that these medications are addictive? That's a difficult question for me to answer. What would you say to that, Dr. Butt?
The antidepressants, especially the new ones, it's quite clearly written on the data sheets and their literature that they're not addictive at all. However, the problem is most of the psychiatric illnesses, the severe and enduring mental illnesses, they have got a course. By rule of thumb, again, it's not precise, but just to give an idea to the general public, say 1/3 of the people, usually it's used for schizophrenia, but let's say even for something like depression, that some of the people, they get one attack or episode and then they grow out of it. There's yet another set of people who have got a relapsing, remitting course of the illness. So as long as they're on medication, they're fine. But with or without medication, when they're going to get another attack, it's hard to predict. but some it's going to be after a couple of years or 6 months or 6 years. So that's the second type of patients, or the group of patients. And then the third type of patients are who always have got what we call as the treatment resistant type, or there's always residual symptoms. So despite the best of the medication and therapy and everything, still there's always some underlying symptoms lurking under the surface, or even they're prominent. And it's in that case, we try to control the symptoms rather than we can't absolutely get rid of them. Now, the duration for which depression should be treated, it depends on the nature of depression. Like under ICD-10, we categorize it as mild, moderate, or severe clinical depression. Plus, first episode depression, the recommendation is to carry on using the tablets even when you're feeling better, up to 6 months or more for a year. And if it's more than a single episode, then more than a year or a couple of years, and so on. So that's the recommendation. However, sometimes, in agreement with the patient, sometimes what we use is the term called drug holiday. So, to save the patient from any side effects or long-term side effects, we offer that to some of the patients who think they're doing really better, or they've not relapsed for a good number of years. I would be pretty sort of careful in stopping someone's antidepressant within 6 months. I won't usually do that.
You won't do that, right?
Yeah.
Well, we've got 30 seconds left, and I did not want to have to interrupt you to say that it's the end of the show. We've got to go, because I wanted to thank you for your very valuable time today, Dr. Butt. It has been a wonderful show. We've had a tremendous amount of engagement. It's been one of those shows that's been very, very popular. So thank you very much again. And hopefully, inshallah, in the future, it would be a pleasure to have you again on board.
Oh, thanks ever so much for having me on the show and answering the questions. And it was really interesting. And thanks for having me.
Thank you. Assalamu alaikum.
Wa alaikum assalam.
Stay tuned to Salam Radio after this short ad break.